Morning, everyone. Before I begin, shall we bow our heads in prayer as we come to do a short devotion? Let us pray. Lord, in your goodness and mercy, we give you thanks for another day. Every morning is new unto you, Lord, and so we pray, even as we come to you, that you strengthen us, renew us, guide us, and be with us. May the words of my mouth, meditations of all our hearts, O Lord, be acceptable to you, our rock and our Redeemer. Amen. Oops. Okay, sorry, the writing's a bit small, but I'm actually reading from Psalm 73. So if you prefer to have something closer to you, you want to look at it, Psalm 73. Let me just read it. If you just want to, you can close your eyes and just hear what these words of scripture say to us. Psalm 73 says, "Surely God is good to Israel, to those who are pure in heart. But as for me, my feet had almost slipped. I had nearly lost my foothold, for I envied the arrogant when I saw the prosperity of the wicked. They have no struggles. Their bodies are healthy and strong. They are free from common human burdens. They are not plagued by human ills. Therefore pride is their necklace. They clothe themselves with violence. From their callous hearts comes iniquity. Their evil imaginations have no limits. They scoff and speak with malice. With arrogance they threaten oppression. Their mouths lay claim to heaven, and their tongues take possession of the earth. Therefore their people turn to them and drink up waters in abundance. They say, 'How would God know? Does the Most High know anything?' This is what the wicked are like. Always free of care, they go on amassing wealth. Surely in vain I have kept my heart pure and have washed my hands in innocence. All day long I have been afflicted, and every morning brings new punishments. If I had spoken out like that, I would have betrayed your children. When I tried to understand all this, it troubled me deeply. Till I entered the sanctuary of God, then I understood their final destiny. Surely you place them on slippery ground, you cast them out down to ruin. How suddenly are they destroyed, completely swept away by terrors. They are like a dream when one awakens. When you arise, Lord, you will despise them as fantasies. When my heart was grieved and my spirit embittered, and I was senseless and ignorant, I was a brute beast before you. Yet I am always with you. You hold me by my right hand. You guide me with your counsel, and afterward you will take me into glory. Whom have I in heaven but you? And earth has nothing I desire besides you. My flesh and my heart may fail, but God is the strength of my heart and my portion forever. Those who are far from you will perish. You destroy all who are unfaithful to you. But as for me, it is good to be near God. I made the sovereign Lord my refuge. I will tell of all your deeds." This is the word of the Lord. Thanks be to God. I think many of us might remember this particularly in the psalm when it says, "Whom have I in heaven but you? And earth has nothing I desire besides you. My flesh and my heart may fail, but God is the strength of my heart and my portion forever." You turn to the person next to you and say, "May the Lord be your strength and your portion forever." Thank you for being here. Dr. Wu and I were having a chat at the back there, and she was saying today the ones who come are the brave ones. Because we will kind of face death in its face and try and think about issues relating to what next and how do we die gracefully. Okay, we talk about ending gracefully, we're also talking about dying gracefully. And it's not an easy topic. My first encounter with hospice care was when I was in KL nearly 20 years ago. KL had a hospice center in Charis, which I used to visit once in a while. And I think we were we tend to think, older people, but when I went there, there was actually a group of younger people. And there was what we call a blue baby, or rather a child who was not young anymore, maybe about 8-9 years old. Blue, in the sense that his oxygen intake wasn't that great, and he was in palliative care, partly because of the issues related to life. And so it doesn't just affect the old, it also affects the young. It's all relating to situations where the diagnosis isn't that good. My relationship with hospice care or palliative type matters went further when I went to Seremban. Seremban, there was this doctor, very kind gentleman in his 80s. He was his early 80s and he was doing palliative care and had been doing it for the longest time ever since he had retired. And I asked him, how do you cope? Because I knew that there were only 2 doctors and a team of about 6 or 7 nurses, and he was kind of like in charge of hospice Negeri Sembilan. So he covered Jelebu, Nilai, quite a long distance. So at 80 plus, he was traveling sometimes up to 60, 80 kilometers and then go pop. Then he come back and I said, do people help you in the work? And he says, yeah, sometimes the IMU students, the medics who are supposed to come into medical practice, they join us for education about geriatric care and palliative care. But a lot of them, he says, is a calling. Many people cannot take it. And his words, I still remember to this day, he said, many doctors don't really want to do hospice or palliative care because it is very frustrating. Doctors are wired to basically heal, but when we come to palliative care, it's more pain management and encouragement and really helping them to end gracefully. He was this bright and cheery man in his 80s. He's probably 85 or 86 now, because when he was 80, it was 6 years ago, 5-6 years ago. And he was the guy who would always go with us into Orang Asli mission trips. At 80 plus, he was looking for the nearest waterfall to go to in the morning and have a dip in there. So I salute people like this who help. I recall one of the things he said as a member of the church. He came to faith quite late in life. His children had become missionaries. This is Dr. Peter Ho. His children had become missionaries and were praying really hard that he would become Christian. And he and his wife had gone through church and were from, or rather had come from mission schools. So they kind of knew the faith, but they had not made that transition to becoming Christian. So the privilege that I had was when I was pastor there, they decided, okay, it's time to basically become Christian. And I had this interesting conversations with him. I said, how do you deal with this, because every time you deal with palliative care, you always have a portion of your heart that cares, that also goes. And he said, what to do, we help them and we try and ease and manage their pain. But he also became a Christian because he found that there are some portions in scripture that were very true. One of which was this: my flesh and my heart may fail, but God is the strength of my heart and my portion forever. So one of the things I recall him saying is like, sometimes we see them and they're losing everything. They lose their faculties, they lose a lot of things. The one thing that they cannot lose, but sometimes they let go of, is their faith and the things that they hold dear in life, which is God. So he says, my hope and how do we help them is to help them to see God as the strength of their heart and their portion forever. And so verse 23, yet I am always with you, you hold me by my right hand. It is our prayer that for those who go through this season of dying gracefully, that they will always sense the nearness of God, particularly in the middle of the night when sometimes pain comes or when a sense of despair comes, that they will encounter the Lord in this. Today we are really, really happy to have Dr. Wu with us. We're also really happy to have you. How many of you have been here? This is your 3rd time already. Wow, brilliant. Can you give them a hand? Thank you for being here. This is our 3rd session. Last week we had Dr. Lo Johnson that was talking about geriatric care or care particularly of mental and psychiatric health in aging, and today we have Dr. Wu with us. Now I have a short blurb that was given to me. Okay, so she's been involved in palliative care since 2002. For you, those doing the maths, is about 20 plus years, so 21, 22 years already in this work. And we thank God for folks like her. My first encounter with her was when I was at Trinity, when she came to the office one time and talked about the work of hospice, Charis Hospice, and the support that Trinity was giving and that form of work. The other times I actually interact is indirectly with her through patients or clients who actually use Charis Hospice, and then we hear of each other and we provide care and concern for each other. So she was 2 years in private hospital, came out to start Charis Hospice, and it's an NGO providing free palliative home care services. Some of you, I see above your mask, your eyes are opening bigger. Yes, it's free. It doesn't mean that there's no cost. It comes with a cost. It's been borne and sponsored, sometimes by churches, NGOs, all the volunteerism. So you know now, Charis Hospice, if you got inheritance or whatever you want to pass, you can think about them, some of the things that they do. And at the end of 2004, she was there with a small core team. So since then, the Charis Hospice has developed, and her team have also developed multiple skills to deal with it. There's a comment in here, the scene in palliative care is rapidly changing. You heard on day one in our video, Malaysia is heading towards aging citizenships. I think everybody here setuju. We're all in that game. And we also know that the cost of care, health care, and even palliative care goes incrementally high as time goes. So it's her hope and prayer that Charis Hospice remains helpful and effective in this community. We kind of believe that our community is a part of that. Just a side note on a personal thing, she just whispered to me she used to be here in Wesley, Penang for 30 years, I think. Yeah, she mentioned 30 years. Some of our old timers here are like, wow. So she was here 30 years ago, then she went down to KL, and then now we give thanks for RGBC, Reservoir Garden. She worships there now. And we thank the church for being her home church and also releasing her to do this work. Would you give her a very warm welcome as I invite her to come to the scene?
Thanks, Pastor Ronald. He has done a good introduction of palliative care and hospice work. A little bit about myself. I don't think I'll be looking for waterfalls. So that may not, I don't think I'll be that energetic. So that's, thank you. Anyway, yeah, I was here as a teenager. I spent some years here, so I was just scanning the faces of some of you. But those of you who are masked, I really can't recognize, forgive me. And you've seen me in your homes. If my team has visited your loved ones before, and if I cannot recognize you, please forgive me. I always give the excuse that I don't have a good memory for faces. Some people are exceptional. They see you once and they remember you for life. I'm not in that category. So do forgive me. Yes, in the course of my work, I have come across many people, and often at funerals too. I told Pastor Roland, we probably have met at funerals before as well. So thank you for the support of this church over the years. Graceful dying for us and loved ones, is it possible? So the topic is graceful dying. And next, as Pastor Ronald has said, you all are the brief ones, because we don't like to hear about it, we don't like to talk about it, neither do we want to see it. And yet the facts are before us. I think we all know for sure that dying is as certain as being born. I won't talk about income tax, only 10% of us pay income tax. All right. I think we need to face this issue. Right. So I'm glad to be here today, and I hope that we will have some good times together. Next. You notice that in this topic there are two key words, graceful and dying. I've tweaked it a little bit to include us and loved ones, because the two go together. So what is my approach this morning? I hope to make it interactive, but allow me some time to take you plunging straight into the uncomfortable deep. And I'll be sharing some articles, stories, and experiences, and sharing some food for thought for you. And I'd like to hear your stories as well. We all know, as Pastor Ronald said, it's obvious before us, Malaysia is an aging population. If you go by the UN definition, when 7% or more have reached 65 years and above, we have hit the category of an aging society. And I think we are there already. In Malaysia, in the 2022 statistics, the average lifespan is, if I'm not mistaken, 73.4 years. About 2 years more for ladies, 2 years less for men. About that. It has dropped a little bit because of the pandemic. And as an introduction to this topic, I like to show a video, 6 minutes, just listen to the first part. How the whole thing of dying has shifted over the generations. Over to you, Christina, right now.
Human beings are the only animals capable of contemplating their own mortality, and they've been doing that for thousands of years. And yet somehow, in the very recent past, we have lost the practical wisdom of what happens as people die. I think that that's a problem. And if you agree with me that it is a problem, then we have to work out what we're going to do about it. When she was in her mid-20s, in the 1920s, my grandmother was already deeply familiar with the sequence of events that happened to a human person as they were coming to the end of their life. And that's because, as a woman, and it was usually women's work, she was doing what women had done for centuries, looking after people at the very end of their lives, in their own beds, in their own homes, supported by their own people, because hospital had nothing to offer once a person was so sick that their death was imminent. And yet, when I reached my mid-20s, in the 1980s, I had none of her wisdom and understanding and knowledge of dying, and that was even though I'd just finished 5 years at medical school. As a newly qualified doctor, I'd spent 5 years being trained to stop people from dying. And actually, if a death happened, it was a thing that was seen as a medical disaster. It was a thing that was embarrassing. It was a thing of which we do not speak. Why the difference? And why within just a couple of generations? Well, think about what happened to medicine over the course of the 20th century. It was not worth going to hospital when you were dying in the 1920s. But by the 1960s, 70s, 80s and onwards, think of the fantastic progress that had been made so that people who were so sick that they might die, of course we took them to hospital because there were antibiotics. There were really clever anesthetics that allowed surgeons to spend a long time unpicking things during operations. There were new and very sophisticated treatments for cancers, for heart failure, for kidney failure. There were intensive care units. There was transplantation of organs, some of that pioneered in this very city. Medical progress was astonishing. Taking dying people to hospital very often saved their lives, and that is fantastic. And yet, by taking dying people out of home and putting them in hospital, we changed our understanding of the process. We lost our ownership of the process and we gave it to healthcare. And we forgot what dying looked like. So, having been qualified for just over 4 years, I find myself in a new job. Having originally intended a career in cancer medicine, I've spent the last 4 years choosing to train in the places where the most sick people were. And then I realized that actually what was really interesting to me was the detective journey of symptom management and the emotional integration of feeling well enough to live a little bit during the very end of life. And I went to work in a hospice. But I'd been working in a big teaching hospital, I'd learned a lot of medicine, I'd seen a lot of dying. We had a patient in the hospice. She was a memorable woman for many reasons. She had been a member of the French resistance during the Second World War. She'd married a British airman, she'd come to live in England. She'd never lost her French accent. She had a cloud of glorious white hair, like a halo. She had piercing brown eyes, the kind of gaze that you feel a person can see your soul. She was self-contained. She was a little bit aloof. In fact, she was a little bit scary. One day, she told the nurse who was looking after her that she was terrified of dying in agony, because if she were to die in agony, she might despair in God. And if she were to despair in God, as a French Roman Catholic, her belief was that that would be a mortal sin, so she would not be able to go to heaven, and heaven was the place she knew her husband was waiting for her. This was a profound existential distress. And my boss said, well, we need to go and talk to her, and you should come, you'll find this interesting. I was 26. Do you remember 26? It's that kind of age, the last age when you know that you know everything. So I went along wondering what I might learn, because I thought I was quite good at pain control. That conversation changed my life, it changed my career, and it's brought me here. Sitting on her bed with me on a little footstool so I can see him and her and the nurse sitting on the chair, he said to her, I'm concerned that you've got worries about what might happen as you're dying. And she said yes, she knew him well, she trusted him. And he said, I'm sorry to hear that, and I wondered whether it might help you if I describe to you what usually happens as a person is dying. And I'm sitting on the stool of all knowledge thinking, well, you can't.
Yeah, we'll stop here for lack of time. You can always access it on YouTube, ma'am. Yeah, so that is an introduction to our talk today. And I'd like us to just pause a little bit and wonder for each and every one of us, what does graceful dying mean to you? And maybe for me to just have a survey of the audience here, may I know how many of you are not retired yet? Okay, some are handful. How many of you are Christians here? Yeah, the majority. Thank you. Yes, thank you. So, I'm going to cover these sub-themes in my outline, in my talk today. The three sub-themes there. Embracing the journey of dying, covering the 3 bullet points, and then nurturing the inner self and planning for the future, another 3 bullet points. And lastly, compassionate care and leaving a legacy. Nothing about physical legacy, because I think you're going to have a talk on that subsequently. So this will be my themes and sub-themes for the talk. First one, embracing the journey of dying. The first sub-bullet. Oh, I must say that I got this from ChatGPT, which is extremely good nowadays, those of you who use ChatGPT. The inevitability of death and its significance. I think we all are very aware of that. Pastor has touched a little bit on the changing demography. I'd like to just take us through all these points, changing demography and related issues. We are in an aging society with death and dying in institution. As Dr. Catherine Manick said in her YouTube, dying no longer is a social phenomenon. It has been shifted into institutions. It's as if that only medically trained people can handle dying. Then the area of individualistic versus community perspective. I may not be fully right, but I think that we are becoming more and more individualistic. Increasing discomfort about dying or caring for the dying in the community. Is that so? Possibly, because medical science has advanced so fast, so much. There's always one treatment after another. And our last phase of life is probably, the author put it as, it will keep us going. We go around and round, keep on increasing treatment. But we are on a downward spiraling of health. And lastly, is there a sense of increasing hopeless, helpless, and tired of life? These phrases are taken from a recent article I read of our neighboring developed country. Next slide. This poet, W.H. Auden, described death as a rumble of distant thunder at a picnic. So, we can ignore and hope that the storm blows elsewhere. We can recognize it, dread it, yet do nothing. We can recognize it, reorganize priorities, enjoy the good weather while they last, and ready to seek shelter. What is our response? I'd like to introduce to you the concept of a good death. I think that some of you may have heard that before. By telling you a few case stories. This is an elderly person with cancer of pancreas. Was diagnosed several months ago before my team came into the picture. He had some kind of stents, we call it biliary and pyloric duodenal stents inserted to bypass obstruction. Then he declined more management. He was recently hospitalized for low blood sugar, pretty common in cancers of the pancreas and liver because that controls our sugar level. Then he was frail, and the family was checking the blood glucose daily. So convenient because you have all these gadgets at home. The hospice nurse visited on the day of referral. The referral came to us on a Friday, and when she called, she got two different versions, so she decided to take the more ill version and went in to visit on Friday itself. Indeed, he was very frail and with poor intake. To us, he was actively dying. So we advised that it's not necessary to monitor blood glucose anymore. And we taught the family on terminal care and aligned care plan goals. And he passed away peacefully 3 days later. It was a long weekend. Is this a good death? As contrasted to a much younger patient I had with a similar diagnosis. All right. It was impossible for the spouse not to check the blood sugar level. Because to the spouse, that was the only thing he or she could do at home. But we said, when we arrive, we have reached the active dying phase. That's really unnecessary to add more anxiety because the range sugar level is expected. But there's no way that we could change the mindset. The next case. This was another elderly with bronchiectasis, which is a chronic lung condition with pneumonia, and he was on oxygen therapy. The sibling came from outstation to help organize post-discharge care plan. They requested for community hospice referral, but there was likely a miscommunication. He was referred to the inpatient hospice in GH instead, and thus there was a delay to move into our referral system. And as usual, things happen on the weekend. Those of us who work in the healthcare line, in the hospital line. A few days later on a Friday, the caregiver panicked when he deteriorated, so called the ambulance. But he had specifically said that he did not want to go to the hospital. The paramedics came, adjusted his oxygen, and left. He died shortly after. Is this a good death? Again, I went to ChatGPT, asked, what is a good death? And interestingly, what came out to me was really good, I must say. I mean, the key elements are all there. We talk about a peaceful, dignified death in accordance to the wishes and preferences of the dying individual. It has to encompass various aspects: physical comfort, emotional well-being, spiritual well-being, religious fulfillment, social connections. But we also know that this concept of good death is very subjective. It has changed over the generations with the advancement of medical technology primarily, society values, and evolving perspectives of end-of-life care. So all these are changing. And then there's the aspect, it's also influenced by cultural and religious beliefs. And the goal of palliative care and hospice care is to promote a good death when the time arrives. But the concept of good death itself has shifted. So what is a good death to you? My team, which has been around for almost 20 years now, we did a small, informal study on the preferred place of death. Because in our Asian community, many of the elderly will still prefer to die at home. But we also recognize that there are factors which make that not possible, not practical. But anyway, we did a short study over the span of 2 years. So this was our results. Well, most of them still prefer home death, about almost 70%. But as I said, not all are possible. And out of this, patients, only about 80% eventually achieve their preference for home death. What about the others? What were the possible reasons? The family overrides patients' preferences. In our Asian context, in our society, the extreme will be when a family decided not to inform the diagnosis to the patient. It still happens. That is one of the cultural value. Secondly, the patient changed or persuaded to change preference. And the third common reason is not possible, poor carer support, or there's excessive emotional distress of family in the terminal phase. It is extremely distressing to see your loved one dying in front of you. Next. I just want to very quickly take us through common sense things because my team will facilitate home deaths because we still value that if there's value by the patient and the family. So what are the differences between care at home and care in the hospital? I think these are common sense. In the home, limited resources, whether it's manpower, materials. So our care plan has to be simple and we need to improvise a care plan. In the home, the family is part of the caregiving team, yet they are also recipients of care because they are going through their own journey of distress. So my team has not only to empower them to be co-partners, we need to support them in their journey. And I'll touch a little bit about caregiver burden. And the environment is obviously different. How senior or disabled friendly is the home? Toilets, steps, the clutter, is there any space for wheelchair, commode chair, the ventilation, the privacy. So these are obvious differences. Next. Yeah. So what is appropriate for the patient and the family? It's up to them. And is demedicalization of death possible? Meaning that we will move away from just focusing on the medical part of care, focus more on the emotional, the social part of care. I have patients who have gone home, and I jokingly say, you bring the hospital home with you, which is possible nowadays too. You have your oxygen, you have your drip, you can even engage in 24-hour nursing, right? Nothing wrong with that, all right? Basic care is needed, but what is appropriate, what is preferred by the patient and family? Is doing less better? Then there's a need to initiate winding down process even before discharge. Can a good death happen at home? Of course, I'll say it can, if there are enough resources. To us, we look at the quality care in the final days. What does quality care mean? Basic things. Good nursing care. The aim is always quality over and above quantity, over extending life. Or at this stage, we tell the family we are not extending or prolonging the dying process. So good nursing care is important. We teach the family which can be done. Good hygiene, good skin care, proper positioning, and good symptom control, of course, that's important. I think that it is a done thing to know that to have a good death, I think symptoms, especially pain, must be well controlled. Then tactful advice on nutrition. And this is always very difficult for the family, and to a small percentage for the patient. As the dying process proceeds, intake will drop, and that is almost inevitably distressing to the family. And fourthly, the emotion support for the family. Next. The last bullet point on this topic of embracing the journey of dying. Importance of embracing the end-of-life journey with grace and openness. Coming back to how the poet described this as a rumble of distant thunder at a picnic. Do we recognize it? Reorganize priorities, enjoy the good weather while it lasts, and ready to seek shelter. Or those of us who are fans of Charlie Brown, I think in our age we do, most of us will know Charlie Brown, okay? And well, he says, someday we will all die, Snoopy. And Snoopy says, true, but on all other days, we will not. All right. So we need to accept, we need to adapt, we need to live, we need to let go. The second theme of my presentation on Graceful Dying is nurturing the inner self and planning for the future. Finding meaning and purpose in the end of life. End of life it is a general term. It may be weeks, it may be months, it may even be a year, or maybe more. As long as you know that life is no longer open-ended. We are heading there, right? And so it can be what we call if I may call it, define it, a pre-terminal, when you are still good, and then the very terminal phase. In the hospice circle, sometimes we encourage you to do a life review, where you ask yourself these questions. And the encouragement is to focus your answers around big life themes like purpose, identity, connections, legacy. This is just an example that I just picked up from an article. But I'd like to encourage us as Christians. You might also want to do a life review, drawing from the Bible. So in this, I ask for patience from my non-Christian friends here that you hear me out as I bring some biblical references in. Romans 12:2, I think we're all familiar with this verse. Do not conform to the pattern of this world, but be transformed by the renewal of your mind. What is a transformed or biblical mindset? Have you ever asked yourself? And that can be the basis for us to do our life review. I like to look at three points. One, at the beginning of life, at the end of life, and anywhere in between. That includes all of us in between the two. At the beginning of life, if I may just quote this, again, very familiar verse, Psalms 139, for you created my inmost being, you knit me together in my mother's womb. I praise you because I'm fearfully and wonderfully made. Your works are wonderful. I think all of us are senior enough, I won't use the word old, are senior enough in life to recognize that what we see in ourselves, what we see in the person we are caring for, if you are a caregiver, it's really hard, honestly, to say that this person or that person is wonderfully made. I'm not sure whether I see you in agreement or not. But that does not take away from the fact that the Creator is perfect, that God, our Creator, is perfect. But the world, His creation, is still tempered with sin. And I think that you and I may struggle through this. And we likely only get the answer when we see our Lord face to face. But just remember that our Creator is perfect. Next. And we are created with different parts to make a composite whole being. The physical part, the psychological part, the social part, and the spiritual part. I will elaborate on that a little bit because this is also the foundation of palliative care. At the end of life, I'm not sure what is your favorite verse. Okay, Matthew 25:21 says, do you want to hear the Lord says, well done, good and faithful servant. You have been faithful with a few things. I will put you in charge of many things. Come and share your master's happiness. Then, where we are right now is in between, at the beginning and at the end of life. I like to propose that Hebrews 11 may be a good reference point for us. Hall of Faith documents not just victories and miracles, but also torture and death. If I may borrow descriptions from other people, I think that the crucible of pain in life can exist in parallel with the fountain of joy while we move from beginning of life to the end of life. Albeit the fountain may be a small fountain. But as we progress in life, I hope that we also value the importance of seeing little things, the meaning and the importance of small things. Verse 39 of Hebrews 11. These people were all commended for their faith, yet none of them received what had been promised. They were still waiting. And verse 13, they saw them and welcomed them from a distance. I believe the key verse is verse 6. How could they do that? The key is verse 6. Believe that God exists and rewards those who earnestly seek Him, even if have yet to receive the reward. What is the reward? A better country, a heavenly one, that makes them live as aliens and strangers on earth. I'm sure we are familiar with these few verses, right? But because I've been in this work for so long, I may be a bit skewed. But I think that one of the greatest tests of our faith is when we go through crisis. And one of the crises in life is when we reach the final lap of our life. When we are no longer as independent, as sharp, as capable as before. How do we deal with this crisis in our life? Will we feel hopeless, helpless, tired of life? As what I quoted to you from the article of a study done in a neighboring country. Nurturing the inner self and planning for the future cannot just depend on ourselves. We need community. No question about that. Faith, as I mentioned, I've drawn from Hebrews chapter 11 just now. If I put it in from a slightly different angle, a faith that believes that God exists and rewards those who earnestly seek Him, made possible only through the death of Christ on the cross and His resurrection. We hold on to God and His word to live in this world, yet not of this world. to be as aliens and strangers on earth because we have a better destination, even though we only see it by faith. And while we are traveling on this earth, we are not alone, as He is with us. But you and I know that this faith, when we go through crisis, is very difficult. We need the support of the community, and that's where community like us here plays a very important role. No matter what you say, that you are crispy, you are not old, the reality is that we are aging year by year. But it is good to be realistically positive. Yes, I talk about looking at small things. Find meaning in small things. The small fountains of joy in the midst of the crucible of pain in life. Being grateful for little things and being in the hand of God and reminded by community that we are in the hand of God. So being in the community is extremely important. Mutual care, mutual encouragement, and mutual directing to God. Will you and I be able to do that as we go through our journey in life? Or are we so polite that when we see our brother and sister struggling in their faith, that we dare not speak God's word into that person's life? Of course, we must be tactful, right? We must be tactful. But is there a place for a community? This whole aspect of compassionate communities is important. In the slide and the changes of demography, we know that we are there, we are heading for not less easy days for all the various reasons. And the community is so important, therefore. Can we develop this whole concept of compassionate communities where we can be on the lookout for one another and encourage one another in our faith? Hebrews 10:25 says, let us not give up meeting together, but let us encourage one another, so that you and I will run with perseverance, fixing our eyes on Jesus. That's what you and I want to do, right? As we do a life review this season, from the time we are born until at the end of life, when we see our Lord Jesus again. Can we be there for one another? But you and I know also there are challenges in building friendship and community, especially when we grow older. We are set in our ways. We don't learn and adapt so easily anymore, right? But we still need to build community. And the last point on nurturing inner self and planning for the future is that of advanced care planning and discussions about medical preferences. When we talk about end-of-life care, these are the possible responses. There may be more. Just waiting. Waiting for things to get better. Or we are very distraught and we doesn't get out of that distraught. Not that it's possible at times. Or we're just clinging on to hope. What hope are we clinging on to? Or we just refuse to talk about it. These are some possible responses in end-of-life care. Another case of mine, an elderly had a fall. A month plus ago, slowly became drowsy, was hospitalized, suspected lung cancer with bone involvement because the MRI showed hydrocephalus, which means fluid accumulation in the brain, within the skull bone, within the skull. Family declined further intervention, discharged home on tube feeding, non-responsive. The sole caregiver is a retired grown-up child. And this is what we are seeing because we are living longer. Either the caregivers are in what I call a sandwich situation where the caregivers have to take care of young children, also caring for the elderly parents, or if the children are all grown and dispersed, the caregivers themselves are retired, taking care of the elderly. Just to stimulate some discussion, do you think it is necessary to have routine discussion with the family before the feeding tube insertion? It's for you to think about. Next. I'd like to show you another video on introducing you to advanced care planning in the situation of a demented patient. This will take 6 minutes.
So are you saying, Dr. Yusof, that my mom will be like this for a while?
Yes, it is likely she will remain in a state of drowsiness. Her dementia has advanced and her condition has also declined over the last few weeks.
She's not been eating well. Is that why she's drowsy?
There are several possibilities for her drowsiness. For now, we can try to ensure she gets optimal nutrition by inserting a feeding tube or by feeding her orally when she's less drowsy with a glucose drip.
Will she wake up to eat? And how long will the tube be in?
The feeding tube may cause some discomfort, but will not hurt her. Given her state of drowsiness, we wouldn't know if she will wake up to eat. It may be in for a few days, or a few weeks, or longer. We need to observe her. Do think about it. If you like, we can insert the tube later today.
Will that make her better, doctor?
You've seen her condition, Mr. Nyo. It is not easy to predict for patients with dementia, and we can only take one step at a time. What we can do now is to provide some nutrition to see if that helps. Think about what your mom would like in this situation, and let me know.
Ma has suffered for so long. She lies in bed most of the time. She no longer recognizes us anymore. I think making sure she's comfortable is more important.
I think we should let Dr. Yusof insert the feeding tube. I think it's best for Ma now. She won't be able to get much nutrition otherwise.
But do you really want Ma to be fed through the tube? Dr. Yusof said that she'll be drowsy for a long time. That means she'll be on the tube for some time. And given her current state, I don't think Ma will be happy about this.
Yong, do you think she will get better?
I don't know. But I don't think that she'll be happy with tube sticking out of her.
Then you rather let Ma starve to death, is it? How can you be so selfish, Yong?
I'm not being selfish. I'm just doing what I think Ma wants.
Ma wants to live on. She doesn't want to starve to death.
Chang Yong, calm down. Ma can hear us, okay? We'll talk about this later, but not now. Yong. Yong, Ma's condition is not getting better. You know that. I really do not know if we can carry on caring for her like this. Dr. Yusof said the feeding tube will take care of nutrition needs. Shouldn't we at least give it a try? Maybe Ma will wake up one day.
Don't you think I know that Mom is not getting any better? She stays with me, you know. At first, she just got lost. And we panicked. And we tried to search for her. And when we found her, she can't even remember my name. Just don't want to see Mom this way, any more than you do.
But Dr. Yusof said it won't be that easy.
I know Mom is strong. It's just difficult to see her this way.
Precisely. Because she's so strong. She may not want us to see her suffer. You know, whenever Ma was in pain, she always put up a brave front in front of us, even when she argued with Ba. When she was very sick, she never really went to see a doctor. If only we knew what her choice was, maybe she wouldn't want the feeding tube.
Mom told me that she doesn't want so many chips in her. She comes a time that she's unable to eat and have to be fed through the tube. Life will be meaningless. She just doesn't want us to remember her that way. I was really not listening to her.
Let's talk to Chiang about this. Maybe we can decide what to do together.
But Chiang, I know that he wants what's good for Ma. But will he listen?
Yo, we had to talk things over. It's because we never talked about this at first, and we never knew what Ma wanted.
That's true. And I remember Dr. Yusof was suggesting to us that we should do some advanced care planning and ask Ma what medical decision she wants for herself.
and we never talk about this, right?
We didn't think that it's important to talk about these things.
So, let's go and talk about it now. Come, let's go.
We'll stop here. Yeah, I've given the prompt that your tea break is ready. So yeah, I hope that there have been some things that food for thought for you, and we hope to go a bit faster after the break to finish my talk and to give more time for a Q&A interactive session. I'd like to hear from you what your thoughts are. When we talk about advanced care planning, just a few takeaway points that it is not a once-off discussion. It is a process because we can never fully predict what's down the road. It will be a process, ongoing process. But what we want to encourage society is to be open to talk about it. And the issue of the burden, most of my patients will tell me that if they are clear in their mind, to tell me that I'm not afraid to die, but I don't want to be a burden to my caregivers. So we always encourage a discussion like this while the person is still mentally clear, and not to think of it as a taboo to talk. Right, with that, I think I need to release you all. How long you have for your tea break?
Right, folks, hope you all can find your places. We'll begin in about a minute, and we'll tell the folks outside to quickly scoff down their chocolate cake. Very tempting chocolate cake. Enjoy now, suffer later. Ian, the other mic. Testing. Yes. Test. Okay. So I hope you take a moment to remember or write down what's one or two of your key takeaways from the session before. For me, it's active dying stage, thinking about now, so that when it happens, you already know. Personally, for me, I know my mom has already said many times, if I die, you please don't tayang me out there for days, and I don't want to suffer for a long time, just pull the plug. I say, you say senang lah, for me, I'm the one who's all that. So sometimes having the clear conviction, having these conversations, and my parents are quite funny. They will mention this, and my mom she's a nurse, so very morbid sense of like, that's it, die quickly, die, don't want to prolong all that. So I know she's quite clear in telling me my dad, on the other hand, will not say anything. So my dad harder, I have to go and dig with him. He does not like to talk about it. So approaching it, finding the right time and having the time to sit down and talk is a tough one. Okay, so some key questions there. So 1 minute silence for you to think your action plan. Now I realize that we have more senior people here than we have those who are still working. So senior people, maybe you can make life a little bit easier for your children lah. And you broach the subject, or you tell them, this piece of paper, please read it, talk to me later. Whichever way it is. When we do visitation, we do sometimes pass one form to our members, or sometimes our members also tell us, hey, if anything happens, I want you to do this. I will tell them, I may or may not be around. So the form, when you fill it up, you say what you want, tells us, which I pass to the team. The team keeps it, so that when the event comes up, then we pull out the form and say, oh yeah, they wanted this done, and all these other things. Okay, everybody settle in. "20 seconds of silence for you to have some white space to process what you heard just now. Then I'm going to invite Dr. Wu to come up again, and then we're going to go into Q&A. Okay, 20 seconds, it's quiet. Okay, close your eyes for a while. Just ask the Lord to tell you what would you want to take away to action. What is God saying to you in all of this, and what are you going to do about it? Okay, right, to make sure that you're all here, can you give a hand of applause for Dr. Wu?
Thank you all. Thank you, Pastor. Yeah, I will pick up my pace a little bit to finish my slides, so I'm going a bit faster so that we will reserve some time for Q&A. Right. So continuing with another case, this is an elderly with multiple non-cancer medical problems. We know that cases are more I won't call them cases. My patients are getting more complex as they grow on in age. Multiple medical problems, including end-stage heart failure, dementia. So institutionalized care. I need you to go back first. Just give me the scenario, Christina. Yeah, as the children are dispersed, so it was difficult for us to also provide palliative care. She had worsening gangrene of the extremities. We had discussed advanced care plan many times, but there was only one child in Penang. The others were dispersed. We offered to do a video family conferencing, but that was not taken up. And the COVID-19 situation made it difficult for us to go in because the institution was also closing their doors. So that was very difficult. And it was difficult to align care for terminal care. So this is a challenge that is happening today, working with seniors and nursing home team. My team will offer to the family, if you want us to make a picture, because we are kind of have more experience in terminal care, but you need to talk to the PIC to allow us to go in, not just for social visit, to actually coordinate care, to actually come on the supervisory level. And it requires teamwork, it requires getting consensus from the dispersed family. And you know the ACP advanced care plan can change with time by any one member. That was what happened in that case, even though another family member disagreed, and so that patient was rushed to the hospital, but after that she came back and she passed on in the nursing home. So these are the challenges of caregiving in the terminal phase, in a dispersed family, in a nursing home. Next. Yep. Coming down to that of compassionate care, the final theme of this my talk today, compassionate care and leaving a legacy. Dame Cecilia Saunders is the founder of Modern Hospice Movement. She says, you matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. So total pain that she proposed is a foundation of palliative care that we look at the physical, psychological, social, and spiritual care. Just to explain to you, when we talk about spiritual care in palliative care, we don't talk about, it's not religious, it's not religiosity. Spirituality has to do with finding and expressing meaning and purpose and connectedness to the moment, to self, to others, nature, the sacred, or significant. It is certainly much more than religiosity. Yep. There's still much taboo, even receiving palliative care. We have occasionally patients or family members who turn down our services because the mindset is that when they receive our services, they're going to die. We tell them, if you're going to die, you're going to die, whether we come into the picture or not, all right? But of course, we put it very nicely, not so crudely like this. So we are always wanting to change the wrong perception that palliative care equals not giving up yet, but moving on and having a good closure when the time comes. I've talked a little bit about the palliative care and hospice care services, then a little bit about role of family and community in providing compassionate care. I quote Rosalind Carter, the former First Lady of America, who said, there are only 4 kinds of people in this world. You are a caregiver, you have been a caregiver, you will be a caregiver, or you will need a caregiver. Which are you? A few slides on the caregiver burden. We will see it increasingly more. And as I mentioned, the caregiver must be seen as a partner of caregiving and also as a recipient of care. Caregiver, when prolonged, is like an extended war of attrition. and multiple dimensions of pressure on the family caregivers: psychological burdens, career burdens, social burdens, economic burdens, family burden, possible disagreements among family members, like in the case I mentioned just now. These are some of the words of actual family caregivers who describe themselves, remaining afloat while being blown, swaying back and forth between expecting relief and fearing relief. Inescapable exhaustion, questions like how long will it be like this, but yet not able to bring it up to the surface. They feel guilty to express things like this. There's this elderly patient of mine with a brain tumor. The sole caregiver is a spouse, very resourceful, very attached to one another, no children. And every time the spouse improved with treatment, hope was revived. So repeated hospitalizations for chest infection. And we had repeated discussions on advanced care plan with the spouse in the final few months. So what was our role then was to build rapport with the caregiver spouse over time by offering him and teaching practical help, active listening, and again explore advanced care plan with him. And the two issues that are very difficult in terminal care for family caregivers is, number one, that of nutrition. Inevitably, am I starving my loved one to death? All right. So my team anticipate that we bring it up even before it happens, to explain to them what happens in the dying phase, right? That you don't have to push nutrition in. So we talk about it sometimes way before, when we anticipate the issue is going to come. And that of sedation, right? If you are going to control your symptoms well, likely that you will be sedated towards the end. But the disease process itself will also make you sedated. Some patients welcome that, let me just sleep and go. But many family members find it difficult to accept that. So there's a reality. So my team will always look into this as part and parcel of our anticipatory care that we offer to the patient and the family. And sometimes at the end, when it's towards the end, I ask the family member this very direct question to explore spirituality. I ask them, at the end of the journey, when it's time to say the final goodbye, what do you think would have been meaningful for you or your loved ones during this very difficult journey? If I can get some inkling of their answer, then maybe we can build on what's meaningful and minimize those which have no meaning, even at the cost of not extending life. So in that particular example of the patient of mine, the elderly caregiver who was caring for the spouse, so I propped him that question one day. And the answer was, I want to be around when my loved one breathed the last. Then I said, if that's so important to you, then keep your loved one at home. Because in the hospital, you likely may not be able to catch that moment. If they're so important to you, keep at home and get extra care in. So this is what I mean when we explore with them. So we ask you may say questions like this, give me goose pimples, right? But this is what my team does when we have conversations with our family caregivers. So there's high caregiver distress, as I said, and the more the dying process is extended, the likelihood there's even more distress. There's a possible burden of regret and guilt. Why is the person not dying yet? But they cannot express that. So, but we are there to listen. We prompt it sometimes. So this is what we do. How does my team prepare them? We initiate the process of dying even before discharge to the home, if we are on the phone with them already, if the referral has come into us. We explain to them the common signs and symptoms of active dying. I actually have a video, but I don't think there's time to show that video. It's 10 minutes. The common signs of active dying. And then we focus on the goal of care, and we de-emphasize technology. So the focus is always good closure for everybody involved. And good closure basically hinges on two key things: excellent communication skills and non-pharmacological management. Not so much interventions, medical interventions, drugs, and so on. Of course, medications are important to control symptoms, but beyond that, it's mainly non-pharmacological management. Yep, someone said in caring for the dying, we need to go from roles to souls to connect with one another. That's what I mean, communication. And there's a difference between cure and care. Cure focuses on disease and treatment, but care focuses on person's subjective well-being. And in the final lab, we are looking at care. I feel touched whenever I see this photo, one of my patients who agreed to share it with us. So the COVID pandemic year has been difficult for many, including my patients and their families. What a balm to the soul when I see kindness and treatment expressed in this picture. David Cicero Saunders has this to say, how people die remains in the memory of those who live on. Think about it, whether you agree or not. That's why my team will always aim for a good closure, because memory can stay on those who are left behind. Just a few words. I think that for those of you who are caregivers, self-care is important, and then these are some of the things that you do to self-care. But as an article that I read, the writer says, forget it, all about that. You can give me one whole list, but I just don't have the time and energy for that, which is also true. But nonetheless, you need to care for yourself if you are a caregiver. And then I have a word of encouragement to those who are tired from caregiving, from 2 Corinthians 4, 7 to 16. Verse 7 says, we are jars of clay, but we have a treasure within us, Jesus Christ. Therefore, we do not lose heart. Though outwardly we are wasting away, yet inwardly we are being renewed day by day. For our light and momentary troubles are achieving for us an eternal glory that far outweighs them all. It is very difficult when the caregiving continues seemingly indefinitely. But I want to encourage those of you who are caregivers. The light can still shine through us, as in the verse just now. We are jars of clay, but we have the treasure within us, Jesus Christ. We are all broken. In our caregiving, you feel upset, you feel very angry. I was a caregiver for 4 parents. And as I look back, I always think that, I could have done better. I think that many of us who have gone through that journey will always have that. Maybe not always. Some of us, if not many of us, will always have that tinge of regret. But nonetheless, we know that reminds us that we are broken. But we have the treasure within us, Jesus Christ. And I believe that light can still shine through us despite our failures and weaknesses. I believe that our testimony for God doesn't depend on victory as the world sees it, but on our authentic dependence on God and allowing Him to be revealed through our brokenness in ways that we can comprehend only much later. Yes, we need one another, as the picture showed you just now. And for all of us who will need caregiving one day, let us learn to let go of some of our ways and preferences, if I may call them idiosyncrasies. I used to talk with my daughter, and she reminded me, she says, Mom, you remember you say all these things. Let us build ourselves up in our faith in our journey towards our destination. The changing end-of-life care scene, we have touched a little bit upon that. There's increasing non-cancer patients. We're not just dealing with cancer. There are many elderly with multiple medical conditions. Somebody says this: the marvel of living longer is completed with the inevitability of decline. What most of us can expect to live our final years is in a merry-go-round of interventions and diminishing returns, diminishing benefit. Just food for thought. The cancer patients are also living longer, and sometimes, nowadays, we are also looking at cancer patients as needing chronic care, but they live with the morbidity of treatment. Their less predictable disease trajectory, some even prolonged. There are more institutionalized care. The cost of care is an inevitable concern, and the COVID-19 infection still has an impact on the vulnerable population. And for my team, we're also seeing very late referrals to us. Over 20% of my patients this year pass on within 10 days of referral to us. We just don't have time to build, to connect, to explore the holistic care approach. So, last few slides. For those of us who are caregivers, can we care and yet let go? Care with a biblical mindset. Let go and adapt. There are certain things we need to let go. And choose if you have battles with the one they're caring for, choose our battles well. For those of us who are living on, in between birth and death, let's live and yet let go. Live with a biblical mindset. Let go and adapt. If I may end with Ecclesiastes 3:1. There is a time for everything. We need wisdom to know in what and when. Final bullet point, compassionate care, leaving a legacy. As I said, I'm not talking about physical legacy of your property, no. I'm talking about reflection on personal legacies. Is there a legacy that we want to leave behind? If I may quote from another writer, our ultimate goal is not a good death, but a good life to the very end. And goal is closely related to meaningful. Will our legacy be what is meaningful in life for us? I like the words on this tombstone. I purposely put it small because I don't have copyright. It is written there, whom Jesus called to see his face. So I think I like these words on my tombstone. I think that's my final slide. With that, I close and we open the time for Q&A.
Thank you, Dr. Wu. Thanks so much. Time for Q&A. Is there anyone who has a question they'd like to pose? Just raise your hand, I'll bring the mic to you.
Hi, Dr. Ng. Thanks for your sharing. Recently, I read an article. It talks about for those who are very sick, there is a way of helping them to die naturally. That is not, how to say, the patient themselves agree not taking in any food. So they will die naturally, gradually, instead of struggling with their sicknesses. So for me, I feel that this is a good way of dying instead of struggling with the sickness. But I would like to know what is your opinion about this, and if we go back to Bible, is it okay to die this way?
Okay, let me just recap on some of the things I touched on just now. I mentioned there are two issues that are always very difficult end of life, terminal phase. One is intake. The other is sedation. You've touched on intake. And I like the way you use of dying the natural way. That's how we approach it. When my team talk to family members especially, because more often than not, the patient is ready to go, but the family members find it so difficult to release, right? So when we talk with them, we will talk with them that we're not here to prolong dying. We allow nature to take its course, right? The natural way is that all of us will come to the point at the very last stage, we cannot swallow anymore. That is natural, apart from few other things. That is natural.
He or she, I mean the patient, still can consume food, but he or she doesn't want to do it because he wants to die faster instead of suffering with the sicknesses. So from the point of view from the Bible, do you think that this is suicide?
Yeah, I have two responses to that, then I'll look at pass over to Pastor Ronald. Right, the first response is that yes, if a patient tells me that, usually not expressed, in my experience, not expressed in a way that I refuse to eat. All right, but because more or just express that I want to die. All right? And I think there's an issue that you are dealing with. It's just that in your case, you are bringing up a person who expressed it through refusing to eat. But basically, the underlying issue is I want to die. So normally what my team does is always explore for the underlying layer. So if a patient expresses to us that doesn't want to eat, the family expresses to us, I refuse, that my loved one refused to eat, we will always go below that. There's always a question below what you see. Right? So we will explore that and try to explore why is a person refusing food. And there are multiple reasons. More often than not, there are valid reasons. From appetite change to difficulty in swallowing to dry mouth to discomfort when you eat. Right? And so more often than not, we will side with the patient for not eating. Because the family comes from a different mindset. If I don't force food in, my loved one is going to die. And usually it's a family that we have difficulty dealing with, not the patient. But in a rare occasion, if I do have a patient who wants to die and thinks by starving himself or herself he will die, then we will of course have to deal with the underlying issue. Why? The spiritual issue about why do you want to die? And we will probe accordingly from that basis. Right? If the patient is depressed, is the patient, are there other issues? Or is it because the pain is not well controlled? You know, so we will bring it up to open and probe if that is there are opportunities for us to do that. Having said that, a depressed patient finds it very difficult to open up. Now that is also another challenge to us, right? So I hope I answered the first part. The second part, which I say I'll pass to Pastor Ronald maybe another time, is I think it's very important for the church, for us Christians, not to ignore issues like this. We cannot say that the Bible says that you cannot talk about euthanasia. Therefore, we don't want, and we come from a very strong approach. I beg to differ. I think that we need to allow dialogue to come up. I bring up to you what I said just now in the article I read, it's a Singaporean article, that talks about the elderly. Of course, I think it's only a small cohort of patients that talks about the elderly feeling hopeless, helpless, and tired of life. And the concern is that our younger generation, we are already seeing increased mental health issues. When these people grow up another 20, 30 years' time, are we going to see that increasingly more? I think the church needs to deal with it face on and not just not just hide behind the curtain, not behind what we are seeing happening before us and in the horizon. Now, one of the articles, Pastor Ronald introduced me earlier by his good friend in Seremban, and the Graceful Dying, talking about why he does palliative care. Now, what is happening even amongst palliative care physicians, palliative care personnel now, which was expressed in this recent article that I read too. And I agree with the writer. He or she said this: the most difficult part about being a palliative care or hospice doctor or nurse is not that we deal with dying and death. It's this issue of why is my patient not dying? I'm not sure whether you get it. All right? It's not why is my patient dying, but why is my patient not dying? When the family finds it so difficult to bring it up, and they are so distressed by it, and we in the hospice team, we facilitate for them to bring it up, at least talk about it. And the other person involved is the patient himself or herself, who is asking the question, why am I not dying? Because I only see hopelessness. I will not be like what I was before. I can't even take care of myself. What is the meaning for me? There's no meaning. Now that, I say, is likely going to be the greatest challenge for us in the palliative care. Maybe not now, but in the years to come. I'm not sure whether I've answered your question.
Let me try and answer this as sensitively as I can. In the past, the Catholic and Anglican churches had sites for burial. This is tradition before the 18th century, and it was commonly known at the time if you committed suicide, you would not be buried in a Roman Catholic plot or in an Anglican plot. Some of that has changed over time. So I'm told that the Anglican churches now have said, okay, even in suicide cases, they will allow burial. So then you might ask, what is a Protestant, or what is the general position in most of our churches? All sins are forgivable. The only sin that is unforgivable is the sin of the rejection of the Holy Spirit, which is in a way a rejection of God Himself. We do not presume to know what is going through the person's mind. So my favorite phrase, OGK, only God knows. So in matters of this, does God permit it, does not God permit it? We say you shall not commit murder, including killing yourself. But we're also not in a situation to assess in the person's mental state or depression or stage of life with all the diminishing things that are going on, whether this person is taking his life away. My job as a pastor is not to try and theologize what's going through his head in a okay, what's God going to do about this? My job as a pastor when the person passes away is to basically comfort the grieving. And it does not help the grieving to say, oh, condemn. It does not help whatsoever. So even in cases of suicide, we will conduct the funeral, we will recognize that this is a child of God, made in the image of God, we return back to God, God settles. I fully agree with Dr. Wu in the questions that we have about the person saying, I don't want to eat because I basically want to expire. And then they will be some of them very biblical also. They say, oh, to live is Christ, to die is gain. And so they say, okay, I want to gain all the stuff. So underlying all of this is more the conversations, and it's never easy, it's never simple. And I guess we should not be the ones to try and resolve and say, here's the answer. It is more always a case of going deeper and ask, why do you feel this way? And like last week when we had Dr. Loh talk about depression, suicide, and all that stuff, these are very real issues. So when there is ideation and there's contemplation and people are now beginning to think of ways in which to take themselves, these are indications that you need to have deeper conversations as to why. I fully agree the natural cause of it is the best approach. So when a person wants to take matters into their own hands, it's not ideal, and you want to ask why. Why do you want to go this way? And begin to make some of these conversations. I'm reminded a few days ago, this Dr. Tan Xiang Yang, professor at Fuller Theological Seminary, was sharing something with respect to Billy Graham. Billy Graham says, when we come into heaven and we actually see who's the greatest in the kingdom, he reckons that maybe the greatest people are not those like him who are preaching to thousands and converting others, but the old men and women who on their deathbed for the last 10 years have been praying for every single rally of his. So there is this aspect which I found true in quite a number of people of the faith who are going through terminal issues where they are drawing closer to God and they are clinging on to God and they have a closer sense of that. So even if you cannot move, you cannot sleep, but your prayer life is there. I like the quotation that we had at the last slide. We have this immeasurable treasure in clay jars, immeasurable. And Paul's idea of this is the weaker we are, the greater God is. So we do want to initiate this. On that note, I think it's because we have sessions like this, that's why Wesley Penang is trying to initiate more and more of these conversations for before when it happens. So that we talk about this method. What if I feel suicidal? What do I do? Why would I want to do it? So meaning and purpose. A large number of people begin to have these ideation issues because they feel there is no longer meaning and it's easier to basically let it go. But our meaning and our worth is not in our ability. The Christian identity and meaning and worth is not something they earn or demonstrate. Their Christian meaning and identity is given to them because Christ died for them. He's the one who says, you are fearfully, wonderfully made. So the Creator says, you are immeasurably great. Not our own ideas of that. So sometimes having these conversations with people, and in the midst of their pain and suffering, they begin to realize what Jesus meant, or what Paul meant. He was faithful unto God even unto death. So accepting the way he would have to die in God's ways. And I appreciate that we have these conversations now, before the pain and suffering sets in, because when that sets in, it's very hard to unwind and unpack and theologize all that. Best we talk about it now. Okay, so I know I'm not going to answer everybody's questions on this one, but we can continue the conversations after. Any other question? Yes.
I'm going to stay away from theology. This is practical. At your first session at the end, you mentioned about tube feeding, and there was a question, how did you word it? Was this discussed? Whether or not the doctors at the hospital should put the tube in. It happened to us. My sister and I were both in town. We were both living overseas. We came back. My mother had severe stroke. She had a very severe stroke years ago, and this is maybe 7-8 years later. All right. So we were in the hospital, and she couldn't swallow, and the doctor said we're going to have to feed her by tube, and it will be temporary for 6 months. We were never asked or discussed, what we were never told. Until now, I still don't know. So please, I would like you to talk about tube feeding. When is it supposed to be? For how long? Well, her 6 months turned out to be 3 years. My mother was a survivor. She had loved life. She was an ex-nurse, very practical, lived alone. She was widowed, and she had 2 girls, me and my sister. We were mostly abroad. So she's very independent. She could drive, and she was very active in the community. So my mother has a great appetite, and we gave her good food. Keep out the oil, lots of vegetables, we pulverized it, fish, steam. Poor thing. My mom loved food, but her favorite food was chocolate and ice cream, not mine. But if somebody cannot swallow, I think it's torture. But we would tell her, we know that she's drowsy, half asleep in semi-coma. But we will always talk very loud, so when we talked in the house, it's as if we're fighting, when people are hard of hearing, and then you start talk very loud. So we would tell her, I'm going to the market, Mom, I'm going to buy this, and your favorite food is chi chong fan, this. So we kept her kind of connected. We assume that even if you're dying or you're drowsy and semi-comatose and drowsy, you can hear. It's the last thing that would go. So I don't know whether we made the right assumption. I have some regret. We never had a discussion between my sister and me with any professional medical person. So her tube feeding went on not just for 3 years, because the last couple of years of her life, the last 5, she had dementia. So she couldn't speak. I think she turned blind, but we kept her alive because we had 24-hour care. We organized it, So now I look back, maybe at what point do you remove the tube? So please talk about tube feeding.
Yeah, I think you bring up, sorry? Yeah. I think you bring up a very practical scenario, which covers several points, okay? Several points. Let me see whether I can deal with them one by one, all right? Tube feeding will be part and parcel of what we call artificial feeding. All right, artificial feeding can be through the tube, through your nose, or it can go through the stomach, or even for short term through a drip. All right, all these are what we call artificial feeding. and whether it's just nutrition or it's just for hydration. But for simplicity, I'm going to lump them all together. All right. In the case of the scenario, the second point is that yes, the reason why we want to talk about advanced care plan is so that every one of us will think through for our loved ones and for ourselves, what is it that is preferred, all right? But even a small study that I showed you done by my team, what is preferred, that was place of death. And we do the same thing about artificial feeding. We will also get a very different, some kind of maybe similar kind of result, where the choice of the patient may not be always honored by the family, all right? So we encourage, that's why we encourage discussion while you and I are mentally clear, where we can talk about it, no matter how difficult it is to talk about it. And often a time in my team's work, when we get into the picture, the patient no longer can express. So we leave it to the family, but we will tell them, at the end of it all, look at what is your goal of care. What is your goal of care? And number two, what do you think your loved one would like? You know your loved one best, because he or she is not in a position to express now. But having lived with him or her, what do you think your parent would want? But having said that, it's always a very, very difficult position for the family, especially if it's one person. So we always encourage team decision. That means not just one child decide, but it's a family to decide. Just give you a very little, I know every case differs tremendously. Just give you an example of my mom who passed away during the pandemic times. Because she had a stroke before, but minor one, she kind of bounced back from it. I think the quality is the other thing that we talk about, is quality of life. And quality of life differs from patient to patient. What is quality of life for you is different from what's quality of life for me. And one of the questions we ask ourselves, or we ask friends who are open to talk about it, is that to what extent are you willing to trade off to get what you want? To what extent are you willing to trade off to get what you want? If you want time with your grandchildren, for example, and you're willing to trade off, meaning that you are willing to be bedbound so that you have time with your grandchildren, that is your quality of life. But to another person, no, I'm not willing for that. All right? So that's what sometimes in our dialogue with our patients and families, we ask them questions like this. So not to get lost. So coming back to my mom's situation, when she had, so she was already struggling with the quality of life because she was wheelchair bound towards the later part. Even though mentally still quite clear, and she could enjoy her food to a certain extent. Unfortunately, I restricted her too much. So one of the regrets, okay? Because you never know when the last stage will come. Nothing very, if it's a cancer patient, I know, I don't restrict. But because these are all these common comorbidities in the seniors, all right? Anyway, put aside that. Then she had a massive stroke one evening, okay? But because I already had a discussion with her earlier, I said, Mom, when the day comes when you're no longer able to swallow, do you want a tube in? And that helped me, because I'm only one of my other siblings. And during the pandemic years, they were not around. All right, so the whole family issue. And because she had given instruction, she had expressed her wish. She does not want to have to be tube fed. She does not want to stay in the hospital. She wants to be at home. And I know that I can take care of her, but not that all of us can. Right? So that was an easier decision for me. But because my siblings were overseas, and that it was more difficult for them. So, okay, we decided we will still admit her into the hospital in ICU. And she was there for just 2 days, and it was very clear. I told them, if she doesn't improve, I'm going to take her back. So there was an easier, clearer decision. And it less guilty, less difficult for me to make as a daughter. It was not so difficult for me. So that's why having a discussion like this is easier, not just for the patient in terms of what he or she is willing to trade off to get what he or she wants, but also for the caregivers, so that you don't feel guilty, you don't regret it, you don't have family contention, family issues on that. Then, how do you decide whether you want tube feeding or not? Either be it in your case for your mother. I think that's an extremely difficult decision because it varies from patient to patient, and prognostically it is really difficult for us doctors to prognosticate. If it is a cancer, then we can tell you more clearer because the trajectory is clearer. But we are dealing with diseases like stroke, diseases like other kinds of diseases, all right, even dementia and so on. Trajectory is a bit more it get more and more frail, but it can be extended over years and years. So that is a very difficult decision to make, and we always tell our family member that really there's no right or wrong decision. Either you make, it is difficult, but just we give you a few guidelines to our patients and family members. What we tell them is, number one, you know your family member best. Think what you think he or she likes, what is quality of life. We're not talking about, but some of them may want to extend life. Okay, that's fine. It's not for us to say no. Okay? Number two, don't decide yourself, do as a family consensus. All right? Number three, we reassure them that either way there's no right or wrong answer. Because if you don't put in the tube, we will say just as tolerated. That means you be very careful, you just feed spoons or whatever, all this, see that your feeding technique is as much as the patient can tolerate it, blend it well, and a little bit, spoons, just sips of water, all right, and positioning the patient well, or let the patient suck and things like that. So we try that. Or if they opt to go for the tube feeding, right? So, but remember that not putting a tube also puts a patient, the common issue of not putting a tube is that family members, because they find it so difficult not to feed, that they will feed, and we will often come up with the complication of infection, of what we call aspiration pneumonia, because the food goes into the wrong passageway. And we will always tell them, if there's a gag reflex, if the patient coughs, please stop, please stop. Okay, sometimes you get away with it until the patient passes on. Sometimes the patient ends up with an infection. But when the infection comes, then we'll talk with them again. What do you want? Again, no right or wrong answer. You want to just manage her, comfortable, manage her symptomatically, or you want to go back to the hospital for treating the infection. So this one can be repeated episodes, like in the case study I sent to you, I shared with you just now about this very close elderly couple. In and out many, many times until probably there's resistant to all antibiotics already. That will come to the stage, resistant to all antibiotics, until I asked the question, what is most meaningful to you when the final goodbye comes? And the answer was, I want to be by the bedside. Okay, if that's the most meaningful for you, then don't send in anymore. And we will support you all the way. My team will support you all the way. All right. So whatever decision that you make. Now the other aspect, if you put in the tube, sometimes if the patient is especially delirious or dementia patients, can't really express to you whether he or she likes it or not. Something about having a tube most of the time is not really comfortable. I'll put it this way. Okay. But the patient cannot express, so we will normally say, let's give it a try. But if you find that the patient is agitating, is trying to pull out, reconsider that. If the person, we still want to respect the choice of the patient. All right. But having said that, sometimes we cannot override the family. Most of the time we get away, they do listen to us, but occasionally there are those who just will insist, the family members will want their way. All right. And the next point is dealing with healthcare professionals. We all come from different angles. Because we are in the palliative care circle, I guess we will encourage a natural way. When I gave a talk about that, when I talked at a hospital meeting to my fellow colleagues, healthcare colleagues, when I gave the illustration about the cancer of pancreas, and I said that we were not going to check for the blood sugar, and because if the blood sugar turns out to be low, hypoglycemia, I'm not going to treat it because the patient is actively dying before my eyes. In fact, one of the in the audience and mentioned to me, aren't you practicing euthanasia? All right. Of course, I will give my answer, I'm not practicing euthanasia. All right. But you can see that this thing of artificial feeding, artificial nutrition, is not just an issue amongst non-medical people, it's also an issue amongst medical people, hospital people as well. But for us, normally we will talk with them. I've got patients, family members, when we talk with them, and they're very clear. So when they get hospitalized, they're very clear to tell the doctor, no, I don't want that. All right? So it's really, the ground is still shifting, I would say. There's no definite yes or no answer. But the fact that we have thought about it, we have talked about it, and expressed our wishes is something I believe that hospital healthcare personnel will give some attention to. I'm not sure how well I answer your question because you already covered many things in the scenario that you brought up.
Dr. Wu, I think there was a question at the back. Yeah, Faith.
The palliative care is in demand now, but it is going to be more in demand in later years as, older people are going to be more in numbers. And so I just want to know what the government of Malaysia is doing about it. And are there many palliative care centers in Penang? I'm not talking about, nursing homes, but proper palliative care center with well-trained professionals and, with a proper monitor system that the inpatients are being well taken care of.
Yeah, I'll try to be brief in my answer to that. Yes, you hit it right.
Sorry.
Yes.
And the cost of it, I think cost is very important for us to know how much we have to save money for our later years.
I'll take the last one first. Because within my team, because we see it, we talk amongst ourselves, and sometimes within my team has 2 doctors and 4 nurses. So we talk amongst ourselves and we say, wow, how much money? If anything you need to save money for end-of-life care. Then somebody will say, how much? Okay. Anyway, so just put aside of that. I think you touched on a few points. I just run through them. Number 1, yes, in our population, you will know that palliative care needs will increase. But having said that, actually, I don't see the referrals to my team picking up, actually. I think it's because the awareness, the acceptance is not really very strong yet. Okay? Point number 2. Is the government doing something? Yes, the government is doing something about that. About how fast the government does something and whether what is on paper is translated into action is for you to decipher yourself. Whether it's in time for you and I in our time, in our era, if not, then hopefully it's for the next generation. All right. In Penang, for example, Penang GH has a palliative care unit. All right, and some of you may know they run a ward in the Para Road, taken over the female psychiatric ward in Para Road. They do outpatient consults. They do inpatient consult when referred by colleagues in the hospital. But the question is that many of these come to them very late also. Okay. As far as the NGOs are concerned, I say that Penang is blessed. We are an urban center. So on the island itself, there are 3 of us, Charis Hospice, Penang Hospice, behind MBS. We do home care service. We visit patients at home. We help to empower the family members to take care of their loved ones. But we also know that with diminishing number of caregivers, that is also going to be a challenge. And then there is an inpatient hospice, that's Pure Lotus. They take in patients. And on the mainland, Penang Hospice covers the mainland as well in the servicing home care, whereas my team only covers the island. We are a smaller team. The Bukit Mentajam Hospital has some inpatient beds, right? The Kepala Batas Bertam Hospital on the USM also runs a palliative care service. Okay, so in a way, we Penang are reasonably covered. But having said that, the need, if really translated into number of patients that really acknowledge or are acknowledged and need palliative care, is going to overwhelm the services available. The government is training palliative care physicians, but it takes 6, 7, 8, 9, 10 years to train a palliative care physician as per our local pathway. All right. Now, the other thing that's developing is that, and I personally feel very strongly about it, is that any healthcare personnel, doctors, whichever discipline we are in, we can practice some basic palliative care, whichever discipline we are in. Whereas, and the specialized palliative care are only needed in the 10% of complex cases. So basic palliative care knowledge and provision of that has to be disseminated down to every doctor and nurses who are in contact. And I hope that we will see that happening more and more. And the challenge is in the nursing homes and the aged care homes. And as much as the government tries to regulate that, I hope I'm not recorded, when they regulate, they need not make things better, they can make things worse. All right, that's what we feel for ourselves, even as issues come in. And it's one of the obvious things is it pushes our overhead up. But you look at the positive side, there are good things about it as well, right? But these are things that are really out of our control. Now, so what the challenge I see for my small team is to work with homes, aged homes, retirement homes, and offer our services. But because they don't answer to us, we have to take a very humble approach. And we will tell our patients, if any of you do have family members who are admitted to that home, please, if you want our services, and we have to explain to them our services, because first of all, we have no idea what we do. So I explain it in 3 ways. Our services, number 1, we help in the symptom control, all right? Number 2, we teach a family member how to take care. And number 3, we help you make decisions. You will continue to have to make decisions. Do you want to go for this treatment? Do you want to go for that treatment? All right, you will have to maneuver all these over the next few months or years until you finally come to the very end. And even then, as an author puts it, you're staring at the cliff. You are really not prepared. Right. So in helping you to make decisions, we don't make decisions for you, but we throw out factors for you to consider when you make decisions. This is basically our role. So in an institution where there's a high-end nursing home, they have their own medical team. We cannot override them. You need to talk with them whether you want our input on an advisory level. And we will try to work with them to give them our opinions. But nursing care is all up to them. In a very poor seniors home, aged home, sometimes we have no choice. But we have to be, my nurses have to be hands-on to actually do the nursing care in those homes. So it's a very whole range. Whether going ahead, scenario will change, I really personally don't foresee that changing much, except that more and more homes will mushroom and the cost will continue to escalate. All right. How the government is going to catch and see the care, quality of care is improved, I have no answer to that. So, so the bottom line is, what do we do?
Okay, friends, the time has come up
Yeah.
to 12:25. We originally arranged for 10 to 12, 2 hours. So this is extra bonus. If you do have questions that haven't been resolved, I think Dr. Wu is still around, can maybe try and catch it quick. But yeah, again, this is not intended to be the be-all and end-all, all your questions answered. It's intended to promote more thinking and more engagement on this. On the aspect of what the Penang state government is doing, if you recall, Dr. Loh mentioned that there is a survey being done by the government on elder care. So if you want to respond to that, you can do that. I think he sent the link. I'm not too sure. Need to check again. That's one. Secondly, you all are voters. You all are part of your constituencies. So one of the ways in which to provoke some questions about this, having gone for this and being now aware of the underlying issues, is to ask your MP, your ADON, your representatives to say, hey, you know, I'm voting for you. What are you putting in place for elder care and all these things? I absolutely agree Dr. Wu, sometimes when they legislate, the legislation creates more hurdles and more obstacles, particularly in area of community care. I see this with the Orang Asli when it comes to child care, children. Okay, you want diploma ECE lah, you want this, you want that, makes it much more harder. I want to end with this thought. Doctor friend of mine shared an article, and we had a conversation over this, and the concern that was raised by the medical faculty was the ability of medical sciences to prolong life does not equate to the quality of life. And a huge amount of the decision making is driven by grief, guilt, fear, and also a sense of mourning. He was a cardiologist, and he said sometimes the children are the ones who are like, they're feeling guilty, they don't spend enough time, and they just don't want to let go, finding it very hard to basically come to terms when that moment comes up. So he said medical science, especially those who are interested in making more money out of you, would quite happily just do what you want them to do. And all you're left with is a person who's there, who has zero quality of life, zero purpose, and you're just prolonging it. For what purpose? And so we're thankful for the church, for Dr. Wu, Dr. Loh, Evelyn in our first session. We've already done 3 sessions. Okay, so the next session is me. We're dealing with before, during, and after funerals in particular. A lot of really practical operational things, what to do at that point in time. And we hope to address the questions there. We hope you've been blessed. Would you put your hands together to thank Dr. Wu one more time? And let me just close in a prayer, and then we can head off. Lord, thank you for your love for us. Thank you for Dr. Wu, Lord, for the time that she has spent and the wisdom that she has shared with us, again, over all these decades of caring for those, Lord, who have returned back to you. Pray that you continue to work these things in our hearts, our minds, our wills, and our emotions, that all we do as a result of this, Lord, in response to your word to us, will honor you, will glorify you, and will accomplish your good and perfect will in this kingdom. We give you thanks, we praise you, and ask all this in Jesus' name. Amen. God bless you all. Have a great Saturday. See you all again at the next session.